Well, it's wonderful to be here today to talk about our team's work. It includes people from both Vanderbilt University Medical Center and the Rollins School of Public Health. This is Project 2 from the Vanderbilt site. And we're focused on improving outcomes for pregnant women and infants affected by the opioid crisis. I always like to center clinically because I think a lot of the work that we do, it plays out in our hospitals and our settings. When I think about the opioid crisis and my introduction as a newborn intensivist, it began with just seeing more infants having opioid withdrawal and just asking questions. What we've seen over time is that there are just huge gaps in the way that we care for moms and babies. And that's really what Project 2 is aiming to fill. So today I'm going to talk about the opioid crisis and its effects on maternal child health, just to level set where we are. I'll talk about Project Two's aims, our published papers and tools, and then a fourth year medical student who has been part of our team for the last 3 years is going to spend the last period of the time that we have talking about her recently published paper in JAMA Health Forum that she also presented at the Pediatric Academic Societies meeting. Well, the opioid crisis has had a substantial impact across the United States. We've seen the opioid crisis have different waves, or some might call them a layered cake, because they're all kind of happening at the same time. First, we saw a wave of overdose deaths driven by prescription opioids, followed by cheaper heroin, when we saw mainly supply side reduction in how and contracting where people could get prescription opioids, and then much cheaper synthetic opioids, fentanyl, became far more popular and far more deadly. It's far more potent than heroin or morphine. So what we've seen in recent years has just been a spike, a devastating spike in fentanyl and fentanyl overdoses that have also affected moms and babies. During the pandemic, we hit a record, the highest level ever seen before of 100,000 overdose deaths annually, most of them from opioids. More recently, however, we've seen a decrease. For the first time since the pandemic, we're seeing a decrease, and we're back to those pre-pandemic levels. It's worth saying that these are still pretty darn high, and we see variation in how states have been affected. Though pretty profound decreases in some states that have historically had very high rates of overdose, like my home state of West Virginia. The substance use in pregnancy is fairly common. These are data from the National Survey of Drug Use and Health. And just to illustrate both substance use patterns as well as how it differs between non-pregnant women. Around 8.5% of pregnant women use some illicit substances. Marijuana or cannabis is legal in some states. It's still federally illegal. That is the bulk majority of the substances we see. Notably here, legal substances are far more common that have pretty profound impacts on moms and babies. Tobacco, about 15%, and alcohol, about 1 in 10 pregnancies. And of course, alcohol is the number one preventable cause of developmental delay in children. But if you look at this graphic here, we still see that substance use is less common in pregnancy than non-pregnant women of identical ages. And this is because women cut down in pregnancy. They're trying to seek out treatment. And that's where a lot of our work is coming in. It's important to know that maternal substance use is complex. I have never met a pregnant woman with opioid use disorder who just starts using an opioid in pregnancy. It's usually years of complexity, and that complexity includes poor health often, poor nutrition, food insecurity, poor prenatal care, social stress, economic stress, and oftentimes intimate partner violence. Each of these can be associated with poor obstetric outcomes and can affect long-term outcomes. From some of our team's work too, we know that economic environments, including county-level economic factors, can also play a role. So we say all this to say this can be complex. And part of what our team is aiming to do is to use real-world data to fill in knowledge gaps. We have clinical trials for some elements, but there are some things that you just can't ask in a clinical trial, and that's where the use of real-world data can really come in and it can be vital. Also important to know that trauma is incredibly common for pregnant women with substance use disorder. 74% from one study reported sexual abuse, 72% emotional abuse, half physical abuse. And ACEs are very common. So that we know that adults who report greater than 5 ACEs compared to those who report zero are 8 times as likely to have substance use disorder and 10 times as likely to have ever injected drugs. For a subset of people with opioid use disorder or people who use opioids in pregnancy, and this is if you use substances like heroin, fentanyl, prescription opioids, or if you are using medications for opioid use disorder, we know that one thing that can happen is opioid withdrawal. And this is called neonatal opioid withdrawal syndrome or neonatal abstinence syndrome. We use the term neonatal opioid withdrawal syndrome because it's frankly just more clear and what it means to the public, to patients, and multiple federal agencies have been using this term for some time now. Well, neonatal opioid withdrawal syndrome is a withdrawal syndrome experienced by some opioid-exposed infants, but it's important to know not all. It's time limited. It's happens shortly after birth. Does not occur in extremely preterm infants. They're too immature to have withdrawal. There are several prenatal factors associated with the development of NOWS and its severity, including additional exposures like gabapentin or benzodiazepines, lack of access to treatment. In some of our work, being in treatment reduces risk of drug withdrawal. And postnatal factors can be associated with the development and severity, including lack of standardization, exclusion of mom and care. We've seen that, believe it or not, in studies, and not allowing breastfeeding, particularly for moms in long-term recovery taking medications for opioid use disorder. But today across the US, about one infant is born every 15 minutes on average having opioid withdrawal. So this is a substantial problem. However, I would say this is just babies who are diagnosed with drug withdrawal. And from some of our work, we think there are probably 2 to 3 times as many who are opioid exposed who have not been identified. And then lastly, infants are affected by foster care placement. So infants are the fastest growing age group in the US foster care system today. About half of them are there due to parental substance use. To put it another way, infants account for 20% of annual foster placements, but they're 5% or so of children. So one of the things that we want to know is how we can modify these outcomes. And we do have some data on treatment with medications for opioid use disorder. These are medications like buprenorphine and methadone. They're the ones recommended to treat opioid use disorder in pregnancy. From some data, it looks like they decrease risk of overdose death, relapse HIV, and hepatitis C. There's actually really good data for this. We know from general studies that overdose risk is cut by about in half with medications for opioid use disorder. And there appear to be benefits too to the infant. More likely to go to term and have higher birth weights, though it does come with some risk of drug withdrawal. The way I think about how these medications work, if you are injecting heroin or fentanyl, for example, you're going through these periods of intoxication and withdrawal, intoxication and withdrawal. That increases your risk of relapse and overdose, and it also is stressful on the developing fetus. So what happens when you're stressed? You're more likely to be small for gestational age, and you're more likely to be born preterm. One other way to think about this is because very, very preterm infants don't have drug withdrawal, when we look at numbers and the impact of the opioid crisis on infants, and we only focus on the subset of drug that have drug withdrawal, we sort of miss the forest for the trees. So what are the gaps? The gaps have been in how treatment influences outcomes versus no treatment. There's actually surprisingly little data here. And we certainly have clinical trials where we compare methadone versus buprenorphine. A great trial, the Mother trial did that. But when we lack data around the effect of treatment, when the most common, at least half of pregnant women with opioid use disorder don't receive any treatment. When we lack those data, it's hard to know what the population effects really will be when we expand access to treatment. There's also a lot of confounding in many studies. So when we compare groups of people, For example, very common approach is to compare infants diagnosed with neonatal absence syndrome or drug withdrawal to the general population. The problem with that is that it doesn't control for all that other confounding that we talked about, all the complexity of the situations that are there. The next is what's the intervention? As we see research, particularly secondary data analyses in this space, and we describe like, okay, infants with NAS or other diagnoses do worse than the general population. Well, what can we do to prevent that? And how can we do it more upstream? So our team for some time now has really been interested in understanding how treatment in pregnancy could modify outcomes, both at delivery and beyond, and for both moms and babies. A lot of the literature really just looks at moms or babies. Looking at them collectively gives you a fuller picture. There's also this linkage between health and non-health outcomes. It's critically important for human services programs like the Child Welfare System. An example of this is the Families First Prevention Services Act, which allows states to use child welfare dollars to prevent foster placement, including treatment. But the evidence-based clearinghouse, there's a burden of evidence for this, includes most of the common treatments are not included at all. So buprenorphine is not included as an evidence-based treatment, and methadone, which has been around since the 70s in the US, is a promising practice. And that's really because there hasn't been any evidence linking health and human services outcomes like foster care placement. And then lastly, there's a lack of tools to do the work, under identification of opioid exposed infants, and really no standards for QI research and beyond. So our aims in this space was to develop an electronic health record-based algorithm to identify opioid exposed infants and some of the common measures of their hospital care. We then wanted to test the hypothesis that treatment with buprenorphine improves birth outcomes for mothers and infants. And in these data, we linked larger sources of data. So we have linked the electronic health record at Vanderbilt with Medicaid data and vital records data. And we also have a whole state cohort to expand our N, where we have, excuse me, Medicaid data linked to vital records data. And so that includes birth and death certificates. And then lastly, our third aim was to test the hypothesis that treatment with buprenorphine in pregnancy for opioid use disorder improved dyadic stability at 1 year postpartum. And what does dyadic stability means? It means that moms and babies are together. And so the way we came up with this term as a team was, okay, if moms and babies are together, like for that year, it's a continuous measure, then baby's still alive, mom's still alive. It sort of penalizes you for readmission and for foster placement. So it's a measure of that. And so we've worked through in our team also understanding who has been placed in foster care using Medicaid claims. So our team has been very active in publishing results, and so I'm going to talk about a few of them today. So first looking at use of medications with opioid use disorder and child welfare outcomes. I won't give that a lot of time today, but just a smaller study using data from Vanderbilt Electronic Health Record and some data collection there to show that medications for opioid use disorder were associated with a reduction in the likelihood that an infant would be placed in foster care when leaving the hospital. Performance of phenotype algorithms, this is aim one. I'll talk about this more here just in a second. Sex and gender variables and data creation and data cleaning. We evaluated whether or not you could effectively use those in electronic health record data. That paper has been published here recently too. Adapting a risk prediction tool for neonatal opioid withdrawal syndrome. I'm going to talk about that one a little bit more. And then buprenorphine treatment in pregnancy, just published in April of this year and presented at the Pediatric Academic Society's meeting. The Sunayak Krishnapar is going to present that here at the end of my discussion today. So let's talk a bit about the algorithms that we developed. And this was a large team and a lot of work really digging deep into the electronic health record and chart review. So while some of these things aren't fancy, they are incredibly time intensive and they're incredibly necessary to really have validated approaches when we pull data out of electronic health record data. This was led by Andrew Wiese and the Department of Health Policy at Vanderbilt and published about a year ago in Hospital Pediatrics. So as I mentioned, we struggle with accurately identifying opioid-exposed infants. And so here's how we work to validate a strategy. We use link mom and baby data from a single large academic health system. This was Vanderbilt from 2010 to 2022. We selected infants that were greater than 33 weeks gestation, no critical illness, and no congenital anomalies using a standard list from the Centers for Disease Control and Prevention. We validated the performance of individual exposure characteristics against medical record review. So, identifying diagnoses and then going and validating them directly in the medical record. And then we use combinations of different measures to see if we had an overall, to maximize the performance overall of an approach. So our infant indicators of opioid exposure included the diagnostic codes for drug withdrawal. This is both the ICD-9 and ICD-10s, as well as opioid exposure diagnoses in ICD-9 and ICD-10. We then also had positive infant toxicology during the birth hospitalization from meconium, this is baby poop, and umbilical cord. We looked to see if they were present, and we also had some quantitative data to look and kind of validate what we had for the laboratory names of opioids. For the birthing parent, we use diagnostic codes from an ICD-9 and ICD-10 for opioid use disorder, the prenatal period to 30 days postpartum. We had opioid prescribing data. Here we were able to have actual prescriptions from Medicaid claims and data in the electronic health record. And urine toxicology for moms during the period, the kind of the peripartum period. We had a structured chart review process that included a sample of 600 medical records and a standardized red cap form. We had two trained study personnel. These were clinicians. One was a maternal fetal medicine fellow, and the other was a neonatology fellow, with overlapping review of 30 records to assess reliability between the two. If we had any discrepancies between the two reviewers, we discussed those as a team. We calculated the positive predictive value with 95% confidence intervals versus the gold standard of abstracted evidence from the medical record of opioid exposure. So here's kind of a large description of the work and how it played out. We had a total of 56,777 maternal infant dyads. We then started eliminating those who had our exclusion criteria, those that were very preterm or that had major critical illness or congenital anomalies. This was a fair amount of infants. And then we looked at opioid exposure with our algorithm. NOWS, positive toxicology, evidence of opioid use disorder, opioid drug exposure on the record, on the medication reconciliation list, or positive toxicology tests. Overall, we had about 1,500 that had a positive indicator. The positive predictive value for each selection criteria you can see here were pretty good. So, a diagnosis of neonatal opioid withdrawal, and this is along with some other work that we've done, had a high positive predictive value. Same with meconium and core toxicology test. You can see each of these individual measures were good. But as you put them together, here's the trade-offs where you start to see some of the indicators. So here's what we're trying to do. We're not just trying to identify each individual measure. Like, it's great that we're identifying is opioid use disorder itself a valid measure, but we want to look at the universe of opioid exposure. And when we do this with one measure, we see a reasonable positive predictive value of 95%. And then you can see our false negative rate, how things play through here. As we start to add more indicators, we start to see improvement of our positive predictive value, but then you start to have this trade-off of false negatives too. So really the sweet spot here is to have greater than or equal to one infant and greater than or equal to one birthing parent indicator. As we start to get more birthing parent indicators, we start to have more false negatives. So moving ahead with the next parts of our work, looking at the clinical risk prediction tool. So currently, the American Academy of Pediatrics recommends at least 3 days of observation for infants exposed to short-acting opioids and up to 7 days for infants who are exposed to long-acting opioids like buprenorphine or methadone. Those with chronic opioid exposures. And this is really based upon the half-life of these medications. But the presentation of drug withdrawal can be incredibly variable by the exposures, by the timing of last use, by variables that we know that matter for the infant. Male infants, for example, are more likely to have drug withdrawal than female infants. So let's put it another way. The way that we do this currently in the US, you have an infant who has a withdrawal risk of 1% who's opioid exposed and one with 88%, and we treat them the same way. And what happens with that is that we have excessive length of stay for the infant who may be over observed in the hospital. In many hospitals, these infants are separated from their moms and placed in the newborn intensive care unit, causes separation and increased costs. So the first round of the work that we did used, and this was actually part of my K, used Medicaid data in Tennessee and vital records data to develop a clinical risk prediction tool. But this was using kind of larger data when we're looking at billing data and vital records. So, here's what we found is a bit of a proof of concept, looking at variables. So here's an example of some of the risks that we found in that first study. So if you have a 22-year-old non-smoker who used an immediate release opioid that's like Vicodin in the 14 days preceding delivery, no benzos or gabapentin, no hepatitis C, which we use as a proxy for injection drug use, babies born at 37 weeks, female, and 2.6 kilos, that's about a 1% risk of drug withdrawal. Whereas if you have a 26-year-old mom who smokes a pack per day using buprenorphine, benzodiazepines, gabapentin, hepatitis C, 40 weeks, male, a little bit larger, 3.2 kilos. It's a predicted risk of 88%. So we published these data in the Journal of Pediatrics a couple of years ago, and we put it online to where you could look, kind of use the tool to explore. But again, the problem with this was these data were old. They were based upon administrative data, which has its own trade-offs, and they were from 2009 to 2011. And so, the opioid crisis has changed quite a bit since then, including different exposures. So the landscape was, a couple of tools that were out there. One that was that predicted pharmacotherapy within the first 36 hours. It was a smaller cohort of 200 infants. And then ours, which used diagnostic codes. So the goal of the work that we just published a few months ago in Pediatrics was to update this using electronic health record data. And so in that, in using Epic data all the way to 2024, here's the measures that we found when we went to use the measures that we did in our previous study and update and add some more that were associated with risk of developing drug withdrawal, opioid use disorder, cigarette smoking, 5-minute APGAR score, antidepressant use, anti-nausea use, long-acting opioids, and gabapentin. So each of these mattered. And I should say that the goal of this is to have a tool that a clinician can use early in life. Ideally, you have something within the first several hours of life where you can say, okay, this infant has a predicted probability of X or Y. But as we look at this predicted risk, here's what we see. First off, the area under the operating curve. Another way to think about an AUC or a C statistic is it better than the flip of a coin? So 0.5 is a coin flip. 1 is perfect. And what does it mean? It means it discriminates between an outcome, having drug withdrawal or no drug withdrawal in this case. So what you can see is the AUC is pretty good. It's close to 1. So its ability to demonstrate is good. But here's the thing, you have to also look at calibration. How well does it function at both the low end and the high end of risk? And here's where we start to see this fall off a little bit. This was true in our previous work and in this study too, where the model works better at the low end of risk. It is better at saying you have a very low risk of having drug withdrawal. We think this is potentially beneficial because if you have a low risk of drug withdrawal, perhaps you could be observed, certainly not in an ICU, and maybe discharged home early with the appropriate follow-up outpatient visits by a pediatrician. The other thing that that the study did, led by Tom Rees, was just to look at, okay, let's create a threshold for drug withdrawal with this tool, and then let's compare it to just using chronic opioid exposure to drug withdrawal. And what we see is that the model outperformed the guideline criteria. Basically, is the tool any better than what we're doing currently? And yes, it is. So next up, Sunaya, a graduating medical student who spent 3 years with us again. I'll say this again because she's a fantastic medical student who I'm happy to say is starting pediatric residency at Stanford here in a few months. We'll dive into her PAS presentation from just a few weeks ago. And then AIM 3 and beyond. So we are in the process of doing our AIM 3 work now. The heavy lift of this is being led by Andrew Weesey, looking at these 1 year outcomes and looking at methods for some of the complexity of what we're talking about. So not just treatment in pregnancy, but what happens in that first year. And then we're looking towards potential renewal and what questions can we ask that sort of drive towards what this is, which is precision medicine for moms and babies affected by the opioid crisis. And I look forward to taking everyone's questions at the end. Thanks so much.